think this is the right one. Unfortunately, you have several things opened, and I want to make sure that this is the correct one. Yeah, it is. Okay. So is it still? Yeah, it's still morning. So good morning, everybody. Um, my name is Mike Fox. If you are here fairly regularly, you've had the mispleasure of hearing from me before, not necessarily in this, but as a facilitator. Today, though, I get to talk to you in terms of a topic that is relevant to at least a certain portion of the youth with multiply occurring needs and multiple points of contact that we discuss here on a regular basis. And if you've seen these didactics recently, they have been very practically oriented with direct linkages of, here's a service and here's how to connect with that, and very practical connections. Today's is just a little bit different. And if I was in the role of Renee introducing me, I would have said, you know how recent didactics have been really useful? Well, here's Mike Fox, and we're going to go a different direction. Hopefully, it's not a different direction away from usefulness, but rather than some very direct practical linkages. This one is to encourage the way you think about um, really identifying and really specifically thinking about diagnosing when it comes to substance use needs or substance use disorders being the more common language when it comes to youth. And if you're thinking, well, none of the kids that I work with have substance use needs, I would urge you to take a look at that. If you're working with more than three adolescents, there's a really good statistical chance that one of those has substance use involved at some level. It doesn't mean at a big diagnosable um, uh, problematically interactive level, but it is probably involved with needs at some level. And so we're just going to take a look at ways to consider that today, not going through the criteria, but really thinking about starting with who are we talking about? And that's the adolescent. And so that's where we're going to start our consideration in thinking about diagnosis, no diagnosis, how do I want to identify with the kid in the family, the level of substance use involvement, does it cross that line into, an identifiable diagnostic category, which is a big consideration. Often we don't get any kind of specific training coming out of school or sometimes even in the work that we do in applying a little bit different lens in understanding diagnostically for adolescents. Children, yes, adults, everything is norm. I'm being biased, but everything is norm for adults. But adolescents are a very specific period of life and a very purposeful period of life. In thinking of that, you may have heard this analogy before that's listed here, that adolescents are like a fast car with bad brakes. That is, they're all go. They are turbocharged. They will approach with high speed anything, but they have bad brakes. And so slowing down, that inhibitory control is reduced. So sometimes you'll hear that analogy. Puberty turbocharges their approach to things and the bad brakes. And, often it will be, the inefficient prefrontal cortical areas limit that slowing down or that inhibitory control. And this is all fair. I mean, it's a useful analogy, right? That, during your teenage years, youth, adolescence, and really you could say transition age years as well, um, that a lot more likely to approach things, get into, more dangerous situations, that sort of thing with a lower inhibitory control. And so it's valid in one way. In another way, though, if it's the only way that we describe or consider adolescence, then it's really limiting our understanding of adolescence because this is a really risk emphasizing view of adolescence. And it's one that's made as compared to adults. They have inefficient cortical maturation. Well, of course they do because they're going through maturation at the time. So it's different. It's not inefficient. They're not deficient. as compared to adults, they're different than adults, and it's a very purposeful period of life. So everybody knows this, but how often do we think it intentionally? Adolescents are not adults. And so that's kind of the framing moving into this consideration. Now, whenever you set up slides for a presentation, you really want to avoid putting this much text in it, right? So I'm not going to read all of this. But I did highlight the couple of areas that I really want to point out moving into our consideration of kind of diagnostic threshold sort of stuff. This is coming from the Promise of Adolescence, Realizing Opportunity for All Youth. This was put out by the National Academies, NASEM, probably about 5 years ago. And it's still, I think, the most comprehensive coverage of this period of life in one efficient package that I have seen. If you work with youth, and if you're here, chances are you work with youth, it's really worth downloading this, which is free. You have to, join NASEM, which is free. And then you can download this and you can see other publications that they have. This one is really useful. Um, some things that they mention in the introduction to this, it's not a brief, this study, um, that the onset of puberty, and when does that begin? The onset of puberty brings about changes in the limbic region of the brain, so in the midbrain, right? Resulting in greater sensitivity to rewards, threats, novelty, and peers. In contrast, it takes longer for the cortical region, which is implicated in cognitive control and self-regulation, to develop. So what's that saying? It's saying that adolescents are wired. They are supposed to be at a place where they're more likely to approach novel situations, to seek out new things, to be more willing. Sound like Star Trek, don't I? To seek out new things with uh, the way to say it is lower inhibitory control. But the ironic thing is, during this period of life, we have way more neural connections than we're going to use in adulthood. And so really the inhibitory control is turned on at a higher level than it will be in adulthood as well. It's just that it has less influence. The approach has more influence, the inhibitory has less influence. Even though they both have far more connections. And through practice, they're actively pruning away those inefficient connections. Underneath, then, consequently, adolescent brains are not simply advanced child brains or immature adult brains. That's something that we should probably have put on t-shirts. We can pass it out to all youth serving folks. But they have evolved to meet the needs of this stage of life. And so it's intentional. Adolescents are supposed to be the way adolescents are. And so we do need to filter our understanding through this is where they're supposed to be. And so many things being normed on adults, and then maybe even some for children, not a whole lot has the intentional inclusion of the consideration of what's going on during adolescence. So what time period are we talking about? A kind of a nice blurb from the Cleveland Clinic here talking about adolescence is the period of transition between childhood and adulthood. And it doesn't mean they have one foot in both camps. You could maybe conceptually argue that, but it is a very purposeful, unique period of life. It's not big kids or little adults. So children are entering adolescence, who are entering adolescence go through many changes. Yeah, duh. So it begins at puberty. When does puberty begin? Well, it's in Western countries and in the United States, maybe even especially, it's occurring earlier and earlier than it ever has before. And puberty begins before you can see that puberty is beginning, before it becomes, noticeably obvious. Um, Anybody have an adolescent at home? There's that day you walk into their bedroom and you're like, oh, yeah, okay, my kid has entered adolescence. Well, puberty has begun long before any of those kinds of, the mood changes and the body changes and the odor changes. It started before that, and it's more subtle and it builds, and it's beginning earlier, than traditionally a lot of the models really consider. Most current ish span, the accepted is that it begins around 10. And you can't say it begins at 10 because it's an individualized thing, right? But how long does it last? Well, it lasts through the end of the neural maturation period. And the interesting thing is this period of brain maturation during adolescence is the second most active period of brain development in our lives. Infancy is the first most active, and that's pretty obvious, right, with everything that's going on. Logically, it would seem like, well, infancy is the most active, and then toddlerhood is the second most, and preschool would be, it would kind of stair step down as we get older and more mature, right? Um, but it's not. Everything that's going on during adolescence with all of these extra connections where the executive management, the cortical functions are making more efficient connections to the existing things uh, that have been hardwired, that have been, set in place through maturational experience. Those connections are being finalized, and it is so active, which really offers a lot of hope if you are working with adolescents, because there is a lot of room for adjustments and for changes in terms of increased health, decreased risk, those sorts of things. There's a lot of room, there's a lot of plasticity for change working with adolescents and even into transition age. That can balance out or ameliorate even really difficult things that have happened in the past. And so I'm biased because my focus is working with adolescents, but adolescence, I think, is the most promising period of life that you can work with. There's so much opportunity for significant change moving forward. So, but working with this age range, working with kids who are in adolescence, it does offer all of these opportunities for really beneficial changes moving forward. But there's also a lot of risks associated with this period of life because those can also move forward. Considering very specifically our topic, and that's considering substance use and the involvement with adolescents. Adolescents and young adults are the groups most likely to use illicit substances. That is more true exponentially with young adults. The use is typically going to start experimentally in early adolescence and then evolve. Young adults, the transition age, are the ones that really have all of the highest percentage of uses. But where does it start? Well, it starts in adolescence. Psychoactive substance use increases pretty steadily, and this is percentage wise. It's not saying for every kid, but percentage wise, typically percentage wise, you see it starting at around 12 with experimental, and then the use can increase, can not does not guaranteed, but can increase pretty significantly from there, and especially if it is something that is involved at a problematic level. Some of you may be working with youth with identified substance use needs, and you're thinking, yeah, 12, that's kind of late. Some of the kids that I work with, they started using at home with a guardian or with a sibling at 10 years old. And, unfortunately, that's not unheard of. But, just statistically, we think about 12 is when you really want to start being aware for and screening on a regular basis for that kind of influence. We know that substance use involvement increases all risks. It has a mutually influencing impact on all the other areas of need. So, pretty obviously, it can increase school problems with attendance grades, the likelihood of graduation, justice involvement, juvenile justice involvement increases, um, risky sexual behaviors, STIs, are certainly increased with substance involvement. And then really the increased difficulties with co-occurring mental health needs. And the mental health needs, really you could expand that and say increasing difficulties with just systemic needs, which would include individual mental health, family, and all of these other areas, because substance use influences those areas and those areas influence substance use, so they are mutually impactful. And we know that of adults who are living with identified substance use disorders, of those folks, 90% started their use during adolescence, which in one way just makes sense, right? Here's really the crux of this quick didactic today. And Renee's thinking it better be quick. You've only got 5 minutes left. Um, This is just to stimulate your consideration of it, and there's no right or wrong answer to this. How do you approach, if you're somebody who tackles diagnosing, how do you approach a diagnostic understanding when you're working with youth when there's substance use involvement? It's presented here as a spectrum. On one side, you can take a very aggressive approach, and then at the other end of that spectrum, you can take a very cautious or very conservative approach. Um, on the aggressive side, and on this side to the extreme, you would say I'm overdiagnosing and then maybe matching more treatment than is necessary. That would be to the extreme. Um, Taking this approach, if you're thinking I'm going to be very aggressive in my understanding um, of considering endorsing criteria with this kid, or actually the aggressive approach might say for this kid. Um, this approach, you would say that, I'm capturing more treatable cases. I know all of the problems that substance use involvement can influence, can increase, a lifelong pattern of problems associated with that. And so I want to be very aggressive in that. I want to capture more of the treatable cases and head off problems in the future. And so, kind of going to drive attack with a sledgehammer, and I think that that's going to be safer. It could increase parent caregiver attention to this. If in your role as a diagnostician, you're saying, I think that this has crossed the line and this is a disorder, bringing that to the attention of the parent or the caregiver and really bringing that seriousness to the surface so that there is more intentional attention paid to that. Potential negative influences by being very aggressive about it. You could increase defensiveness in the youth. You could increase defensiveness in the family. And, if you're saying, oh, it's this, and you're pushing one direction and they're pushing back the other, what does that set up? If I'm arguing one way, they're arguing the other, well, no change is going to happen in that. So, I mean, there's risk in that. And also there's a stigmatizing risk that once you receive a diagnosis of something, it's really hard to be undiagnosed, right? It's hard to have that fall off appropriately in the future. It's something that kind of stays with us for a long time, or if not forever, right? And with substance use, it's going back quite a ways at this point, but there is still that lingering belief that you know, once I'm gonna use inappropriate language here. Once you're a drunk, you're always a drunk. Once you have crossed the line into full-blown disorder, you are always going to live with that. But does that apply to adolescence? I don't know. At the other end of the spectrum of consideration and thinking how to approach working with folks, if you take the really cautious, the really conservative approach in terms of endorsing criteria and saying that it's crossing a certain threshold. That approach, it could reduce exposure to unnecessarily intensive levels of treatment. Involved in that, there could be some concerns about iatrogenic impact. And there's a fancy schmancy word to take out of this, iatrogenic. It is the treatment itself causes harm, or even more specifically, you could say the treatment itself is causing the condition. It's snake biting its own tail kind of thing. You think about that if you put a kid who maybe doesn't have that high level of need and you put a kid into a high level need, say in an IOP group, does that exposure then actually increase the likelihood that that kid is going to be using other substances and continue use? So, I mean, you worry about that. Um, the cautious approach by not saying we're crossing some sort of magic diagnostic line, it might permit more open explorations of motivation towards change. You can work on those motivations, that readiness to change without the stigma associated with it. But then there's also a risk in this direction too that you can miss opportunities for early intervention. You can miss those opportunities for intervening at a time when it was most meaningful. So there's no right or wrong answer to this, that, it's wrong to be very aggressive. It's wrong to be very conservative. But you do need to consider if you're somebody that does this kind of work with folks and really provides this type of service with folks, to think about how am I going to approach it? There are several slides left, and I'm going to send these so that you can see them. But other areas of consideration that I'm going to move through very quickly here in thinking about how are you going to endorse criteria that will maybe suggest either yes or no for a diagnosis. How much weight do you give to the kid's interpretation themselves? It's easy to kind of overlook that because, well, I know better. and what you're doing is risky, and you meet this criteria and this criterion and this criterion. Well, how much input do we give to the youth's perception of that? How much input do we give to the parent or the caregiver's input into those considerations, or the perspectives of other people who have a stake in this and have experience in this and have a view on this, like child welfare workers or magistrates and judges, probation officers, folks that might make referrals that would have input into this. And then how much do we involve our own values and expectations? A couple of things just quickly, well, it's the top of the hour, just to think about coming out of the DSM. The DSM notes that, substance use is really driven by the activation of the reward system. Well, duh, that one's pretty easy, right? That one makes sense. Couple of things that they mention that maybe don't fit as cleanly with adolescents. They note that individuals with lower levels of self-control, which may reflect impairments in brain inhibitory mechanisms, may be particularly predisposed to developing substance use. Think about that as it applies to the criteria that are listed to consider crossing that threshold into diagnosis. What does lower levels of self-control mean for an adolescent? Right? We've seen what the normal adolescent is and what's going on developmentally. So do these criteria apply directly? A couple of other things to mention here, and then I'm going to uh, jump off of this and turn it back over to the more important part of today, which is our presentation. The essential feature that they describe of crossing that threshold is a cluster of cognitive, behavioral, physiological symptoms indicating the individual continues using the substance despite significant substance-related problems. Just think about in adolescence, how do they consider significant problems and how much does this impact? How much value do I place on this as an adolescent? Right? Because they consider information differently than adults do. And an important characteristic of substance use disorders is an underlying change in brain circuits that may persist beyond detoxification. Well, what does that mean to adolescents? They're actively undergoing all of that brain development. So how does that apply? So these are just things to prompt your thinking about when you're working with adolescents and you're somebody who's in the role of making a diagnosis or even understanding somebody who's coming to you with an active diagnosis about how these really apply. And so, again, there's no right or wrong answer to this. You can approach it very aggressively, you can approach it very conservatively, and there's valid reasons to do it on both sides.